Dr. Stone, thank you very much for your presence here on a very important topic. I appreciate and join my colleagues in concern about veterans who commit suicide, and I look forward to working with the chairman, certainly the ranking member on the legislation that we introduced. And I put Veterans Crisis Line in my iPhone, as you indicated, and I never thought about it, but it's an opportunity that if someone presents themselves to me, I have some place to go and go quickly. So thank you for highlighting that for me. I wanted to comment on something I heard you say just a moment ago, and I think it's pretty close to this quote. Veterans will have more choices, but VA will remain the integrator of veteran health care. I think that's a desired goal on the part of all of us, and I thought you summarized the Mission Act with those few words very well. I remember the testimony of one of the representatives from the American Legion when we had our hearing over in the Visitor Center, and the point that he made on behalf of the American Legion was that care that originates with the VA, even if it occurs in the community, is still veteran administration care. And the importance to him of that was that the VA, and therefore members of Congress, but veteran service organizations have control, someplace to go to when perhaps something is not quite right, that the place that we can still complain, even when something happens in community care, the VA is still in charge. And in many ways, the use of your word integrator, again, reaffirms what I heard this representative from the American Legion say about this issue of care in the community. The VA is still in charge. The VA is still the place we can go to influence something that's happening to a veteran that we care about. So I'd welcome any comment if you want to highlight anything more about that. If not, I'll ask you a couple of questions.
Senator, I appreciate that. This is, when I returned to the VA last summer, people talked about foundational services. What's foundational about the VA? To me, what's absolutely unique about the VA healthcare system is the lifetime relationship we have with our patients. And you're always a veteran, and we've got you for the whole lifetime. And we should be the experts in the complex disabilities that are caused by service. We know in our chronic living facilities and in our nursing homes that over 50% of those patients have degenerative disease of the spine, hips, and knees with chronic pain. It is the VA that understands that. And therefore, even when we're buying care in the community, we should be the integrator that brings everything together for that veteran.
Thank you, Dr. Stone. Can you tell me at least some of the data that you utilize to determine drive times and wait times? What did you learn from the 2017 Merritt-Hawkins survey on wait times across 30 health markets? How did this information then help create the standards that will be utilized under your regulations? Go ahead. Dr. Matthews.
Thank you very much for that question. We did quite a broad-span market analysis. As Dr. Stone mentioned, we looked not only at public sector, but also a fair number of commercial plans, state insurance departments, marketplace expansion plans, even Medicare Advantage. All of these have wide-ranging approaches to network adequacy and in general how they build their services for their beneficiaries, for their patients. In looking at those numbers, we definitely saw some general trends, as well as did a comparison of our own wait times and accessibility within our facilities, and did that same sort of look at Merritt-Hawkins, as you mentioned. Merritt-Hawkins, of course, does a wide span of analysis in different metropolitan areas, some quite large like Boston, some smaller and a bit more suburban, if not closer to the rural side. And there's definitely not general trends of wait times across the board. So that wasn't really much to rest on. So instead, by again looking at the different comparison of plans, what we were hoping to do was to stick with an industry standard so that our veterans, perhaps even used to the same sort of standards that they had through TRICARE, through even other private payers, might have an expectation and one that is quite reasonable about when they could actually receive care within a specific wait time or distance from their home address.
So it's safe to, I mean, I should be comforted by this, what you just said, I assume, because that means that decisions that are being made about what the access standards should be are based upon information across the board from other healthcare providers and other networks to make certain we're doing as well or better on behalf of veterans. If there's a science, in a sense, behind the decisions that were made in access standards.
That is accurate.
I also hope that that means that we can better predict costs into the future. Is that more than a hope? Is that more than an aspiration? It will improve the VA's ability to estimate its costs?
That is also accurate.
Mr. Chairman, my time has expired. I wanted to point out that Emily Wilson has been one of my staff members on Veterans Affairs issues for the last 4 years, and this will be her last hearing, and I want to acknowledge her publicly as a person who has cared greatly for veterans in Kansas and across the country and has been an integral part of our work on this subcommittee. And she's off to help folks at the Department of Defense, and she will be missed. And Emily, thank you for your service. Thank you, Mr. Chairman.
Thank you, Senator Moran.